And oh my goodness, they're on week 8. It's going by really, really quick. We know that this week we've been doing those good old reviews. Next week we have our exam number 3. I want you to know that I did invite Professor Luminoso's class. I spoke to Professor Luminoso and I said, open invitation. Anybody who wants to come next Thursday, 6 p.m. Let's hit the concepts. Let me tell you what you know, what you need to understand so that you all can give you your best score. It's not going to be me sitting there talking on a PowerPoint. I'm going to throw things at you. Give me answers. And why are those answers what the answers are? So week 8, we have a discussion question, and we do have NCLEX questions. I think everything's up to date. All your discussion questions have been graded. So, you think the discussion questions aren't anything, but let me tell you, the concepts in them you're going to see again in quizzes and exams. So to understand them actually does help you. I don't always cover everything in class. I can't. I don't have time. So let's go ahead and let's do your PowerPoint. 123 slides. So I'm going to be whizzing through some things that I think we don't need to discuss. But if somebody does want to discuss those things, you let me know. I can stop and we can. So it's all up to you. You tell me what you need. So GU. So GU, in assessing the function, it could do it in many different ways. I mean, a simple little urinalysis is the number one. And then we could go into all the ultrasounds and x-rays and procedures. And all they measure is structural, measuring, how is the urine flowing? Is there reflux going on? Or is there infections we can't find? So all of those are. Now, urinary dysfunction, something's going on. The kid's showing you something. Well, all of the definitions are in the notes page, which is right underneath this. Difficulty urinating, frequency, going too quick, urgency, I have to run, urinating, or at night when you haven't done that for a while, soiling the bed, too much urinating, or how about they stop urinating? All of those things happen. Now, let's look at some abnormalities. Phimosis is a male's penis with a foreskin that it's so tight it doesn't pull back. It doesn't pull back. Now, one of the biggest reasons males and young infants have urinary tract infections is because they can't pull that foreskin back, and it underneath that foreskin and penis, it creates an infection, which goes into the urethra and into the bladder. So when you have phimosis, usually what we want to do is do something. If we can't pull it back and clean it, we're going to do a circumcision. So sometimes if we try to pull it back and it gets stuck, it's called a paraphimosis. It just gets stuck, and it actually is an emergency because we can't get the foreskin back to where it should. Epispadias, hypospadias, again, the male penis. Does the urine come out the end of the urethra, or is it on top, a hole been made? It's not here. So somewhere on the other upper side, there's a hole, and it happens for many reasons. And hypospadias is underneath, all right? And again, this is something that they need the foreskin. What they do is they do surgery. And one of the things about surgery and a male organ, female body organ, they want to do it before they're old enough, before they're potty trained, because it does end up with bad feelings. Because remember, it's castration. The older toddlers and the preschooler are worried about that. So we try to do it as early as possible, see, before 18 months. And we, again, don't do a circumcision, because if you look at the pictures, they fillet that penis open on the top or bottom. They create a lumen. They use the foreskin and close it back up. And yes, there's a catheter in there to hold that hole open, that lumen open. You're there for 10 days, 14 days, we do nothing with it. Just keep that tube in a bladder, or the urine is going to go everywhere. Bladder exstrophy is simply the bladder was born outside the body and not inside the body. All of the bladder works. It's not a problem. But we need to be really, really careful about taking care of that bladder, which is outside. So again, be careful of that skin underneath getting excoriated, using sterile gloves, right? Keeping it infection free. And these children, usually within 2 days of birth, they're gonna open up the midline, it's called, open it up and put the bladder in, and it all works. It's just us as nurses keeping that skin free from getting red and broken down, because they still have to close that up when they're done, right? As I said, sometimes all of those urine examinations, ultrasounds, CAT scans, oscopies are all because of an obstructive uropathy. What could occur with an obstructive uropathy? Well, it could be a kidney stone, a calculi, a tumor, strictures. Could be it's not open and it can't get down there, right? So many times, when you can't get urine to go down into the bladder, where does it have to go? It only can go backwards. So we really need to do something to get that urine out of that kidney, or that kidney is going to be like hydronephrosis, full of fluid, and then it's going to become a kidney that don't work. So again, we'll do some sort of diversion surgery, making sure that that urine can now flow to the bladder out of the body. And again, toddlers, the problem with it again in children is again that body image thing they're going through. So it's that distorted body image as we get even older. So again, we want children to be able to do potty training the way they should, be independent. We try to get it done before that happens. We know if this happens later on in school age, yes, distorted body image. And think about an adolescent who has issues with their penis and urinary things. We really know that they're going to have like, they feel less than because their penis doesn't work the way it should or the way that everybody else does. So again, it's all about that sexuality. It's a lot of mentation and thinking about that. So a UTI, most common in little girls, again, with that short urethra, and it's really close to the anus. And they love bubble baths. They love cute little tights and these cute little polyester type underwears. And they're the worst things we could do for a little girl, especially one that's having frequent urinary tract infections. So because of those things, we know that cotton underwear are good. They shouldn't take bubble baths because the fluid in that bath water is going to go up inside and create infection and vaginitis, etc. Also, it's about potty training and wiping, and that's the E. coli from back to front. So, urinary tract infections common. Again, what do you see with a urinary tract infection? Well, maybe it's that dysuria and frequency and all of those things. Sometimes it's just a fever, vomited once, and their tummy hurts a little. And sometimes it's all you see with a urinary tract infection. But if we see all the other ones, well, that's easy. But what's the treatment? Well, infants under 1 year old usually will be coming into the hospital for IV antimicrobials. Remember, their immune system is very weak. They need something strong to get rid of it. And again, the first time, not waiting until the kidneys are, you know, destroyed or, injured. So again, what is our big thing with teaching? So again, fluids are number one thing that helps prevent urinary tract infections. And again, making sure when they need to go urinate, they go quickly. They don't hold it. Kids hold it because they're not going to want to miss anything. So no. Clean the perineum, absolutely. Every diaper change, front to back. Avoid those bubble baths. They sometimes, and a child goes into a bathtub, warm water. What's the first thing they do? they urinate. It's just, or they quick get out to urinate. But they say try after the bath. I don't know if that's going to happen. Those white cotton underwear, loose fitting pants. I know the cute little tight ones are really nice and look really cute on kids, but little girls shouldn't have them. And again, fluid intake. Now, nephrotic syndrome is not anything to do with kidney failure. So, nephrotic syndrome, the kidneys are working. This is not kidney failure. What it is the kidney says, protein, I don't like you, and they urinate it out simply. So, you're losing all of your urine, of the protein in the urine, okay? Because of that, many things happen. They get swollen, edematous, because even the blood, which all the protein is, all that protein is gone too. So, what are some of the things? Common in boys, 2 to 7, sometimes has to do with the T cell and the immune system, could be. And you'll see, as I said, generalized edema. And the one thing is that weight gain. So these children, they gain weight. I mean, even if their mouth, their tongue, they just don't feel well. They don't eat because they keep biting their tongue and their inside of their cheeks and don't feel good. Their blood pressure, though, now remember, it's not kidney. It's not anything with kidney failure. Their blood pressures are normal. With kidney failures, they wouldn't be, right? And when we look at the urine, massive protein, massive albumin, it's the same word, albumin protein, same word. And these children are at high level immunosuppressed for getting infections. So we do give steroids, and the steroids help reduce the protein that's coming out. But remember, they're already, apt to get infections, immunosuppressed. Remember, steroids does it even more. So again, making sure we hand wash, and as nurses, we're doing all of those things to prevent our germs from getting to them. Remember, if there's not protein in the blood, where does all the drugs go? Because the drugs go into the intravascular system and the drug hops on a protein. And the rest is free drug. Well, if you don't have much protein, you're going to have a lot of drug in that blood system, right? So you have to be very careful with giving medications because these children will be in medication toxicity quicker than any other child. They don't have that protein sitting there. Now, you say, well, they're swollen, give them a diuretic. It doesn't work. But what do we do? What's the nursing care? What do we tell these children? No salt, whether they have swelling or not. They just, low salt diet. And they say no fluid restriction unless they are full up with edema. Parents are taught to record every day their weight because increase, decrease is shown. Is it working the medicine? Is it not working? Having them up, moving helps those things. I and O, and again, that preventing from infections. These children will not get any vaccinations that you can't get with immunosuppressed. That means live vaccinations. Now, acute glomerulonephritis happens, the acute glomerulonephritis, due to a strep infection that wasn't treated. And what they do is, so it attacked the throat, we didn't treat it or undertreated it. It could cause rheumatic fever, right? That's one of the things it could cause. Well, the second thing is acute glomerulonephritis. So usually, you'll see them stop urinating, getting headaches, intake is more than output. They get swollen, they get periorbital edema, they look swollen. Then usually the ones with that acute stage treat with antibiotics and these kids turn around quickly. But sometimes it can linger on, so we have to be careful. So Wilms tumor, it's a kidney on the a kidney tumor. It's a nephroblastoma. And it is this fragile thing that attaches. And if we touch it too much, it can cause little micro pieces to go in the peritoneum cavity, and it goes everywhere. So the big thing is do not touch this because it will cause, some sort of metastasis on this child. Okay. So sometimes the only time we find it is we're just doing a checkup and we're just checking everything. It needs to have radiation usually or chemo, one or both, and they do surgery and get it out, and they usually do okay. Our nursing, what we need to know, don't touch that abdomen more than you need to because we don't want to have little pieces of metastasis going into the body. So what they do is they take the kidney and the tumor out, and these children actually do really well post-operatively, routine. You just got to make sure that they're urinating and that their bowels work. Now, hydrocele is too much fluid in the testicular sac, and it causes swelling. If the child is born with it, we'll watch it. If it gets to be over a year, we'll do surgery on it. Cryptorchidism, the testicles are not in the scrotum where they should be. You might have one down or you might have none down. It doesn't matter. Remember, when we're examining for that testicles in the sac, you need a warm room because the warm brings them down. Cold makes the testicles go up. Okay. So a warm room is really important for this. And we know that we need to do that by about a year. They try to get them out. So the other thing is, one of the things about cryptorchidism, we've got to be aware that some of these children end up that they're infertile when they get older, or they can have testicular tumors. So doing testicles exams, just like women do breast exams, men should do that. Nursing care with this is make sure they have a scrotal support, after they get these testicles down. Again, teaching testicular self-exam. And again, how old was this child when it was done? Remember that private part things on younger kids, they felt that they've been castrated. Older kids understand but feel embarrassed. So remember, how do you speak to that child? So, as I was talking all along about the age of children and working on their genitals, either male or female, it doesn't matter. Remember that these children are in that exploration, and that we do need to make sure that they understand what we're doing and it doesn't hurt them. What we're doing is going to help them and get it on their level of what they understand. So skin protects the body, right? A lot of things can happen to it. Sometimes we can see the skin is telling you something systemic's going on. What about anaphylactic shock and a rash going up everywhere, right? Sometimes we know that. Skin color, skin tests we know are allergens. If you ever had allergy testing, they take like 10, 40 of them and they just patch these little needles on your back, and then they look at them a day or two later and it itches and you just want to itch it off. I've had it done. With skin, we're going to look at all sorts of things, and we know that medications, medical treatments, all can change the skin, the hair, etc. When you are documenting any sort of skin condition, now the whole face, including the eyes, is red and skin is peeling. You know, Make sure you document it as well as you can. Yes, we can describe it, we can tell the upcoming nurse, but again, this might be what we have as that pathway for the doctor to know what's gone on. Itching is huge. Kids don't know. If it itches, they're going to itch, right? And we know that underneath their fingernails are full of bacteria. They're going to itch all over. And so we're going to give medications, creams, ointments, whatever it is that we can do to help them. There's all sorts of type of skin conditions: the macule, the vesicle, the crust, the papule, pustule, the wheat, the ecchymosis. These are the terms that when you're describing a skin condition, you're going to need to go into your nursing notes. It's difficult to remember which one is which. You can describe what it looks like also. The hordeolum is the sty in the eye, right? Anybody have them? They hurt, and of course with a child it does too. Strawberry Navis, we get that off. They actually put creams on that, which will shrink it up, okay? And we can do it as soon as the dermatologist says, okay? Port wine nevis is at birth, and there we can dull them up, but again, they'll still be there. They'll never completely disappear. Cafe au lait is that dark brown and light sort of differences that you see in the skin. It's also called like hypopigmented, and that's just, in some cultures, you're going to see that. What about lupus, butterfly rash, right? That's classic when we talk about it. Sometimes children come in not feeling well, and that's a sign that they're showing us. And we say, oh, that's lupus. Let's look at it a little bit further. We know that sometimes there's around the mouth, we see chin, cheeks, we see papules, scales. Sometimes we see this as a zinc deficiency. So, as I'm saying, the rashes can tell you what does a child need, and prevent further problems, right? And then that vascular birthmark, you can see how it changes over the years. Sometimes they dissipate, and sometimes there's just a hint of them there. Sometimes they just go away. Sometimes there's steroid creams, hormone creams, all different types of ones that I've seen used. So miliaria is that prickly heat that we do see. And we saw it because it's sort of sometimes the kid sweats and it causes it. I've seen it in their chins, I've seen it in tubings. And remember, these children will be, and infants, usually this one, will be trying to itch it. So take off the stuff, keep it dry, keep it cooler as we can. If it's in the diaper, make sure that we change the diaper frequently. I think a dirty diaper with a diaper rash is the one big thing that keeps the kids awake at night the most, if you think about it. So again, our goal, any of these rash type things, make sure you keep them clean and dry as you can. Seborrhea, dermatitis, cradle cap. Some kids are born with all of this white stuff on their head. And the big thing is parents want to scrub it and get it off right away. No, it's not going to happen in one time. So there's all different things. Now, this dermatitis looks like another one called eczema, but it doesn't itch. And these children, what we do is we wash it with normal shampooing, and we take a fine tooth comb very gently. We comb it, and then there's nothing that says to put a little bit of oil on it, and then overnight, and then in the morning do the bath and get it out. So both of those things can work. As I said, diaper rashes, I think that's the hardest thing for a baby to have because they have to have a diaper on. They need to urinate, they need to stool. They've got all this red broken out area and it hits it and they scream because it hurts. So our goal is to prevent the future diaper rash dermatitis, right? It could be due to foods we just introduced. It could be due to laundry detergent, could be due to soaps that we've used, creams, what you wash the children in. I mean, all of these things. And it could be the diapers. My children did not like Pampers. They didn't like Huggies was their choice. And conversely, my grandson did not like Huggies. He get this big rash and he liked Pampers. So got to figure it out. Very frustrating. Acne is a big thing, especially with children that are adolescents and they're growing. It's all about body image, right? Again, just to clean it like they should, not to over clean it, because that's what children want to do. and then prevent anything greasy around their face. And then, of course, the dermatologist has multiple topical and oral to help them. Now, herpes simplex, we think of a cold sore, right? You've seen children born, they can get it and it can spread. So, what is the treatment? Well, when we see them get their first type of lesion, it's to put on those antiviral ointments. And if it spreads, they're going to do antiviral ointments. And we're also going to be doing to those children, giving them oral antivirals. And that's going to decrease what's going on. Eczema, children with itchy, rashy, oozy sores all over. Do you know it's rarely seen in breastfed infants? When it occurs is when we add normal foods. So, what do we do about these things? Well, something is getting them sensitive. Is it the creams, the lotions, the jellies, whatever? Sometimes it's immunizations that do it. And it's being on top of it. Sometimes it's making sure the nails are short and then keeping them with lotion. And then, of course, following it up in case they're infected with whatever they need, antibiotics, ointments, or, sometimes it's a lot on their body. We put them in the baths. I used to always say the Aveeno baths were always something that worked well with everything else worked, and that's the one that did. Again, corticosteroids can be given, but remember the long-term effect with that. And of course, anti-itch. If they're itching, we don't want them. Their nails and they're everywhere, right? In the mouth and everywhere. So ointments should be washed off between any application of that child with that eczema, etc. Cortisone creams, should be avoided. Now, we can treat the symptom, but what caused it? So cortisone creams are the last resort because what do cortisone creams do? They absorb. And now you're getting steroids in that infant. And of course, steroids have underlying risks and benefits, right? Again, putting on ointments, make sure that they're warm bath, their pores are open, and then put on just enough ointment. I always tell them more is worse, less is best. So put on smaller amounts and make sure you work it through, okay? They can, if the kid is going bonkers and scratching like crazy and it's their head, they can put things on like elbow restraints. They can't bend the arms, so they can't reach their head or wherever it is they want to itch, okay? And again, steroids, infections, got to be really, really careful with steroids. Any person. Staph infections, MRSA, big
Yes, I
thing.
have a question about eczema, if you don't mind.
Sure.
So, you say it's a bacterial infection, or okay,
It,
so
no, no, no. Eczema is a reaction to the skin that has a breakout. It can
okay,
get infected and be a staph infection.
okay.
It's not an infection that caused eczema. It's an allergic response to some allergen, something they've been in contact with,
So
or
even
something
if
they
they
ate.
change the environment, or like the place is changed, or the detergent is changed, they still keep having that reaction.
It could be an allergen to foods. I mean, it could be, I mean, at the point where you've changed everything, then
Mhm.
it's time to do allergy testing. Is there something else I'm not catching? Is there a dog, a cat? Is it the air? Is it mold in your house? Oh, there's so many things. So you start with the changing of stuff, then you go into looking at the allergens, what it could be. Is there a causative reason?
Okay, thank you. That makes
No.
sense.
Right. You're welcome. So, staph, you usually see little pustules. So, these little sores that are oozy gooey. And many times, all of those sores in children, we will, put some ointments on them. We know MRSA is the methyl resistant staph aureus. This is the one that called dangerous. We really can't cure. So these children are put in special isolation, contact isolation, so that we don't spread it around into yourself. Now, skin syndrome looks like we put through water on the child, and it was burning, and all of this um, skin started peeling off thing. It's just a syndrome. It's caused by staph. Impetigo, common childhood thing. It is staph, highly contagious. My grandson came to my house, and his mother said that he scratched behind his knee a mosquito bite. But I had him there for several days, which I always do, and it was getting bigger, and it was ooey and gooey, and I went, "This is impetigo." So at that point, I had a good staph cream, Actroban, Mupricin, and I put it on there, and it still wasn't quite there. You need either that topical, but you need oral when it's resistant like that was. And it went away. Big thing again. Cut the fingers, nails, make sure that they're not touching it. It is dangerous. It does spread, okay? Even to you putting on creams and lotions. Fungus can be anywhere. It could be in your head, could be in your feet, it could be, jock itch. And again, it is a fungus. Treat it with a fungus medicine. Pediculosis could be body, could be in the head, could be in the pubic area. We call those the grabs. Again, that is treated with a medication. And remember, kids with their toys, we need to take toys they've played with when we find out they do have head lice, is to put it in a container. And what you do is close it off to air for a week before you let them come back out to air. You could get scabies. It's very similar to the other, type of lice, etc. But scabies itches, and the eggs and they bury underneath the skin and they lay more eggs. And the treatment is permethrin. But remember, if a child has any of these, we have to treat the whole family or make sure that the family doesn't have it. They usually will say the whole family's treated. Burns. What does that happen and why? Well, many times the pot handle, they pull it and it comes on them, right? Or the hot water heater is set too high, just because, not because of abuse. They turn it on and they put the arms in it and they burn themselves, or they climb in the tub by themselves. Could be electrical, could be chemical. They got stuff on them. These are real things that happen. Now, was it a happenstance? The kid did it. It was nobody's did it to them, or was it abuse? Was it neglect? These, as a nurse, are the things you have to think about. There are sort of body surfaces. No, I'm not going to take and tell you how much each body section is. You know that a head is less than a chest. We know that the size of the piece of body part you're looking at, it's bigger, it's going to be a bigger percentage. And we know with burns, we're going to give fluid boluses to get their fluids back as much as we can, okay? But when are we concerned about burns? Well, what if it splashes by the face? What's the airway like? That's our biggest thing. Whether it's smoke, whether it's burns, anything. Do you see anything around the face that looks like an inhalation burn? That's the one, as a nurse, be scared of, because you might not see that respiratory problems immediately. It might come up pretty quick, though. So always assess airway. We know children's skin is thinner, so they burn deeper quicker. We know that their body they could go into shock and heart failure quicker. They needed fluid resuscitation as quick as they can. They're smaller. The areas that are burnt are going to be larger just because of the fluid doesn't change, okay? So remember, these children, they are going to need good protein, good calories, and What if their mouth was burnt? They're not going to get all that oral. So they need good fluid balance in them. And remember, areas that bend, fingers, wrists, elbows, knees, that we make sure that that skin doesn't toughen up, that they still can move the way they need to. That's one of the big things. Sunburn, living in South Florida. You see kids out there all the time, outside and no sunscreen on. I've got to say, today, I see it so much better, parents making sure their kids are covered. We know that there is a lot of problems with sunburn. We know that number one, it hurts, and that we have to rehydrate the skin, and rehydrate that child also. What about the opposite here? So now we got frostbite. I used to live in New York and I know what it is to be really cold. Remember, if you're cold in let's say your hands didn't have gloves and they got really cold, just like this thing. Remember, you can get some of the feeling back, but again, you can't do it quickly. It must be done very, very slowly, okay? And just because we get them heated up doesn't mean all of the pieces of the fingers are going to stay there. So, endocrine system. So we have the nervous system and we have the endocrine system. We know the endocrine is all about the metabolic needs for the body. What do you see when you have a problem with your endocrine system? Usually you'll see them tired, they don't want to eat, they're not gaining weight, sometimes the liver is big. I mean, a lot of time endocrine, like I said, remember hypothyroidism is one of the things that we see at birth when they don't stool. And why is that concerning? We don't give thyroid hormones good enough, their mentation isn't going to be the way they should be. So that's why we look at all of those things. It's why we do a PKU and chromosome studies on these children, and then we look for thyroid hormones. Let me go into some more. We know that hormones are secreted by the thyroid. We know that they look at your T3, your T4, your TSH. We know sometimes children are born without it and will require forever, they'll be requiring thyroid hormones to live. We do know that sometimes they get older and they have something called Hashimoto. It's an immune thyroid that, again, it's not working right, but we can't take it out. We just have to keep replacing those hormones. So you can see how I'm talking about thyroid and the importance and that cognitive. They're not awake, alert. Their developmental levels are far beyond where they should be. So screening for hypothyroidism is now mandatory. What do you see with hypothyroidism? You're tired. An infant too. A kid's their skin is dry, just like an older child or adult. They're floppy, they're not moving, they're constipated, their hair's dry, brittle. This is all just like older patients. Same sort of things, but in that infant size. So we give those thyroid hormones, we watch it, and how do we know it's working? Well, we're going to see them. Their hair is going to be less brittle as it was. They are going to not be sleepy as much because they're getting their hormone. They're going to be more alert, and if we've caught it quick enough, they're not going to have a progressive mental retardation that doesn't reverse. Now, what happens with too much thyroid? So not enough, you're tired, you're down, you can't move, etc. Too much, you're awake, alert, and your heart rate is racing, you're irritable, you're losing weight, and you feel sweaty, right? It's the opposite ends of the spectrum. Too much thyroid replacement, as in you're at home, you gave an extra dose of thyroid medicine. What do you see? That's what you see. Now, diabetes, the other one I wanted to talk about. Chronic metabolic problem. It's where your pancreas says insulin, you're not going to work that good. And what does insulin do? Well, insulin digests carbohydrates, the sugar. And the thing about that is you need sugar to live, right? You need sugar for the calories. So, how do we know when you're with diabetes? Well, what they say is adults go to 100 as their fasting blood sugar. They let a child go to 126. So it's a little bit more sugar they let them. And then we will see these children start, even younger children, when they first get diagnosed, all of a sudden they've got their sugar. Now you can't digest. The body says, oh, I'm so hungry, but I can't digest sugar. What am I going to do? All right, let's go to fat and let's go to your proteins. And the digestion forms a product called ketonuria, ketones. And when you see that elevated blood sugar and those ketones, you're running into problems because you're not digesting the sugar that the body needs. And if you don't get those things, what's going to happen? You're not getting calories. So you're not getting the growth you need. You know, one of the things with diabetes, we may have to make sure that we make sure that that insulin somehow is in the body and we're digesting good sugars. What are those signs and symptoms, even in adults, about they don't take care of their blood sugar? We talk about blindness is a big one, neuropathies, kidney disease, circulatory disease, losing toes and fingers, etc. Now, does that happen in children? Well, it can progress to that if we don't take care of the problem with the sugar now. There's type 1, type 2. Children are type 1 if they're diagnosed early on, 2, 3 years old. Type 2 could be an adolescent who is obese. So, do they ever go from 1 to 2, the younger ones? No. They never had insulin, it won't change. But a type 1 adolescent who follows a diet, gets their sugar under control, can become a type 2. Excuse me. So, diabetes, there are 3 P's you see. They're hungry, polydipsia. Why are they hungry? They're not digesting sugar, they're not eating it. They're like, give me some food, I want some. Then they're urinating a lot and they're drinking a lot. What do you see? What do they look like? Well, children with type 1 diabetes who haven't been diagnosed or on that DKA side, when they walk into the ER, they are lethargic, they're weak, they're pale, they're dry, they don't look good. So it is something that you can see progressively happen or suddenly. You will see absolutely glucose in the urine. I mean, how much would you expect? 4 plus, right? If they are to that point of hyperglycemia. Because what happens when you don't have sugar you can't digest? It sits there and it just becomes more and more. It's not like all of a sudden it goes away. So, again, the body starts using protein and fats for energy. And it also gets that glucose levels higher, but they're getting their fat and they're getting their protein, they're getting what they need. And, these children, need to find, at that point, get to the physician, to the ER, and get their blood sugars under control, and give fluids and they'll feel better. Now, we do spot tests on these children. As I said, 126 is okay. We don't want it to be any higher than that. They'll do glucose tolerance tests, just like pregnant women, right? And of course, we'll be looking at that glycosated hemoglobin, that hemoglobin A1C. Now, adults at 6.5, they consider you diabetic. They go up to 9% when they're talking about children. So there's differences there. Also, look at that 12% indicates poor control. We think 8, 9% on an adult is poor control. So children have a little bit more freeway there, okay? So DKA or diabetic coma, what is it? They come in. Well, they're got high blood sugars, they got high proteins because the insulin hasn't been available and the sugar's getting higher and higher and higher and higher and higher. So what are you going to see? You're going to see ketonuria, and you're also going to see elevated blood sugars. You're going to see when you do a blood gas that those pHs are low. Now, do you know what a normal pH should be? 7.35 to 7.45. That's normal. Do you want to know what the lowest pH I've seen on a child with DKA was? And it was scary. It was 6.8. That's like below life status. The child made it and did well. So what did we see? Well, they were dehydrated. They had that fruity odor in their mouth. They were nauseous. They didn't know really where they were. And, the kid was in the ER, thank goodness. So goals of diabetes is to prevent these sort of things, well-balanced diet, make sure they do insulin, they follow their glucose, taking them as needed, exercising, and try to make this kid feel as normal as they possibly can. The one thing you don't think of, and something that I've seen, is they have beef and pork-based insulin. There are some cultures that don't want pork in their diet. So as a nurse, you may be the only one who realizes that and gets that child for that family what they do need. So we need to teach them about the pancreas that's not working, how to do those blood glucose, what is the diet? Which numbers of this one do we give? Getting dietary in there to talk to them. Exercise. Now we know that you think skin and foot care is only adults. It's with children too. They will get that neuropathy. They will get, those sores that don't heal. So absolutely being aware of skin, foot infections. We know stress, emotion all causes a problem. And if they're traveling, what do we do if they're traveling? Well, insulin needs to be in a cold environment. Make sure they know that. They keep it in a cool pack. And when they get to the place where they're going, put it in the refrigerator. And we know if they need insulin, if they're sick, they have surgery, their demands are going to go up. So being aware of it. So nutritional management, again, normal growth. And we know that children, they base the food upon who the child is, how big they are. Cultural is being a part of it and making sure that they get all the food groups that they do need, okay? That's what the whole thing is. Remember, insulin, we need to rotate the sites, just like adults. And I've seen young kids get a pump. At 7 years old, I saw a little child with a pump, and he knew how to run it well. He knew how to bolus himself. He knew, and he showed me what to pump, how to work it. So it's a good thing because think about it. They have one needle and it's taped there. It's tiny, itsy, and it's taped on with a tube to a machine, and it's one stick a day. And they could go ahead and give a bolus if their blood sugars are too high. So it is a wonderful thing. Clear before cloudy, you've heard about that, insulin. And remember, with children, again, I mean, that's where those little pumps go. That's what it is. I think they're awesome. You could leave them in there a week, sometimes more. I mean, they're changing all the time the protocol there. Now, insulin shock is what? What do you see? You see it, all of a sudden the child will get diaphoretic, shaky, nervous. Their level of consciousness isn't real there, and it could be from too much insulin. It could be because you didn't eat, right? Could be part of it. Or it is that maybe children are growing, or they were out doing activities and all the time, and now they didn't because they didn't feel well, and that insulin is still burning up, but they're not either eating up all their sugars on them. So when you see insulin shock, what is the treatment? Well, initially they need some sort of sugar now. They need to be given, whether it's a hard candy, orange juice, milk, even that. If commercial pills and stuff, give it to them. But remember, as soon as they feel a little better and not so, dizzy from the low sugar, that they get some protein or starch, because that sugar only lasts for a little time. Okay. And if they are passed out, you can't give them anything orally. That's when you give glucagon. It's an IM injection, and that gives them sugar right away. So Meiji phenomenon is that rebound hyperglycemia. It's all you really have to know about it. And we know it has to do with insulins and the way it works. And there's also Samoji and Dawn syndrome. It just has to do with getting your blood sugars. They go up and down at night, no matter what you do. And it's something that you don't have control of, but you have to be aware of. Sometimes you wake up in the morning, you need to have something sugar next to you. Type 2 diabetes is that adolescent, usually in that they're obese, they're sedentary, they don't move. So what do we need to do? They need to get up, do some exercise, and follow a good diet. Um, Initially, they'll put them on insulin, and they'll put them on some oral pills too. Many of them can be turned around if they follow what they're supposed to do. So here we are, communicable diseases. These are all definitions. Communicable diseases comes from one to another. Incubation, I think of this with chickenpox. The time between when I met you that you had chickenpox till the time that I break out. Vector, was the insect or animal? Was it a tick? Pandemic worldwide. I mean, talk about COVID, pandemic. Epidemic, something that happens just locally. Opportunistic is caused by an organism that a child can fight off. PCP pneumonia, HIV, that's a big one. And then healthcare associated infections, MRSA, a VRE, it's a bunch of those. So the virulence of your infection, it's the resistance to the disease is why. Like, why am I not going to get a disease and you're not? It all depends on you, your age, your physical, emotional health, what you have inside those phagocytes, your immune system. We know sometimes we've been exposed, never had it, we've already built up an antibody. So types of immunity are important. So natural, I'm born with it. Acquired, you're not born with it, but you either had the disease or you're receiving vaccines or immune serum. That's the important one. I acquired it. Now, active is when myself, I produce my own, and passive is that you've given the antibody to me, but it don't last long. I think acquired is the one that we're working with today, working with, you get an influenza vaccine, a COVID, and immunization, and that is going to help us prevent getting it. Aseptic technique, all patients, right? We do them as clean as we can. Standard is gloves, or mask, whatever we need to do. And we know that depending on the organism, it depends on what sort of our equipment are we going to go where, right? Airborne. It's actually your bacterial meningitis too. That's your droplet airborne thing. And that's something we'll wear those really special masks for. That's the one we wore for COVID. TB, varicella. As I said, varicella is airborne. It's in the air. We see it. That child needs to go to a room to protect you and everybody else. So the N95 mask. Contact precautions is what they have can contaminate me and contaminate somebody else. Whether it's, these children will be in a private room, will be covered head to toe, we'll wash our hands before and after. That is contact. Droplet is when it's in the air. We want to put our mask on, and gown and gloves so that we're not, again, carrying this germ from me to somebody else. And then, no matter what, hand hygiene. You wonder why the school doesn't like when put your nails on and pretty, and they're just so pretty, and I get it, and putting just gel on, but it was seen, and it was part of the career that I lived because I used to wear the nails and all that. The artificial nails, they found out that bacteria, whatnot, do grow up underneath, and the chance of spreading to your patients is a lot more. They also say, bracelets and whatnot close to the patient, you shouldn't. And again, it's just protecting that child or that patient while you're taking care of them. Again, preventing infection and hygiene. Of course, immunizations are important, proper food storage and preparation, pasteurized milk. How do you defrost? How do you cook your meat? When do you put in the refrigerator? Community towels. I don't use community towels. I'll drip dry at that point. And then insects, ticks, right? And they say today, no sandboxes. A lot of bugs can be laying their eggs in there, etc. Those are all the names of all of the rashes again. And healthy people. Healthy people is a government net thing that tells you things, what a goal is. What do they want for their community, for their people? And one of the ones is 95% of all children should be immunized. And they've done all goals, to decrease obesity, to increase reading, to decrease dental health. I mean, there's multiple for everyone, and the government has programs set up for it. So vaccines, we know that you're acquired your health. We know that if we're doing any sort of vaccines, immunizations, we always worry about any sort of anaphylactic shock, right? So always, if we're giving them, make sure there's epinephrine, and they should be watching this for at least 20 minutes after the immunization. If you're allergic to baker's yeast, you shouldn't be getting a Hep B. Eggs, avoid influenza and MMR, and neomycin, the IPV, MMR, and the varicella vaccine. No, you're not tested on them, but in the future, you're in children, they're going to ask you. Contraindications is when you're immunosuppressed, pregnant, you need permission for that, or if you have an infection going on. And remember, it's not just you. Is there somebody immunosuppressed at your house? That could be a contraindication. Not all of them, but some. And if you are on corticosteroids, steroids, you cannot take live vaccines, okay? Or if you're sick. Bioterrorism, well, this could happen for many reasons. Well, you never know what's going to happen on in life today, right? Remember, children are more vulnerable because they don't have as a developed immune system. And remember that children, today, if we see something's going on, there's all sorts of drugs, etc., available for them. Have you ever been in an emergency before? I mean, I get, hurricanes, South Florida, the hurricane place. Always be prepared, have your stuff. Medicines is a big thing that some people forget, and that they have water. And children, infants, do they have diapers? And do they have their food? Sexually transmitted disease, it could go from mom, it could go to the baby, it could go from sexual abuse, which I've seen actually. It, of course, as they get older and experimenting with drugs, it could be contaminated needles. And remember, the nurse is required to report sexually transmitted diseases. So remember, if there is somebody who sexually has a sexually transmitted disease, we need to know who they were with because they need to be tested. Because where else is that disease going to? Is it HIV, right? Of course, you always maintain the privacy, but it's things that we do need to ask. So, again, with nurses, when we're talking stuff like this, it's give them the privacy. Of course, that confidentiality is a big thing. They feel less than because they have whatever disease it is, and make sure they understand what they need to do to feel better. HIV, AIDS in children. I've seen triplets born of an HIV positive mother, one had AIDS, one had HIV, and one of those children had nothing. So, what was the difference? I think it was the antiretrovirals that were given at birth and during the end of a mother's pregnancy. We know that this child is apt to get diseases that don't hurt us, like pneumocystic pneumonia. For us, as a normal person without HIV, it doesn't hurt them. And remember that these children do need good immunizations and follow up because they do have a lower immune system. So a lot of stuff in there, huh? Who wants to win the Cahoots today? Nobody?
What was your question?
Who wants to win the Cahoots? You do? No? All right, let's get going. I know you're all tired on this Friday evening. Week 8, chapters 29 through 32. Bunch of chapters, a lot of different stuff. The nurse caring for a child with nephrotic syndrome is alert to which classic symptoms of this disorder. Remember, nephrotic syndrome is not renal failure. It's the kidneys that say in yuck protein, I don't like you, and spews it away in the urine. So these children, because they've gotten rid of all of their protein in their blood, so they're hypoalbuminemia, they've spewed all of their protein out in their urine, proteinuria. It forces a lot of fluid to go interstitial. And that's why there's a generalized edema and you're tired and weak and don't feel good. Multi. Genitourinary surgery is especially stressful for preschool children. What factors lend to this stress? Children that are preschoolers are afraid of castration. Remember, they are really fixated on their genitals. Even at that stage, you're starting to masturbate. Normal, it's fine. And then they think that they're this surgery because they've had it all along. Like, what do you want to do this now? It's like some sort of punishment to me. And all of these are real. So again, it's the nurse explaining they did nothing wrong. It's just something that make you work a little better. What special considerations are related to long-term prednisone therapy in preschoolers? Well, what does prednisone do? So prednisone, you are immunosuppressed, so you're at increased risk for infection. So you have to delay your immunizations with it. It does not alter the nutrition. Might make you even eat more, right? Steroids, I know that whenever I had to take a Medrol dose pack or something, it's hungry all of a sudden. And then enlargement, no, it does not do that. It's all about infection, immunosuppression. To prevent urinary tract infections, which is the best beverage for the nurse to recommend to keep urine acidic. You'll be surprised. And it is actually apple juice. Believe it or not, you say orange juice should be, but no, it's actually apple juice. And again, how do you prevent urinary tract infections? Extra fluids. So if you have to give extra fluids, give some apple juice. When weighing the diaper and subtracting the weight of a dye diaper, the nurse records 30 grams and documents how many mLs of urine did that child have. Doesn't give you enough information, does it? So if you're weighing the diaper and you're subtracted the weight of a dry diaper, and then there's 30 grams left. 30 grams is equals how many mLs, okay? So if you had it, and I'll put it in another way, you take a diaper off a baby. That is a 30-gram diaper. And it weighed 60 grams when you took it off wet. When you weighed it was 60, the dry one's 30. Guess how much urine? 30 mL. So gram per ml. Another multi. Strategies to prevent a recurrence of urinary tract infections in a child. What are you going to do to help them get UTIs? So white front to back, lots of fluids is the big one. And wear the cotton underwears, those nice white ones. And I know little girls don't want them. And we shouldn't take bubble baths. Good job. When do you correct the hypospadias of a newborn? Well, let's take you back. Hypospadias is when it doesn't come out the tip, it comes out underneath. Now, you're working with surgery about a penis. When should you do it? You should do it before they're really potty trained, and it's usually before 18 months. Makes sense, right? They're feeling perineal, they're going to castrate me, I've done something wrong. So we try to do it before that to Draw that away. They're not going to think like that. Foreskin is retracted and very tight at the shaft of the penis, and you're unable to return it back over the head of the penis. What are you going to do? So you pull the foreskin back and it's stuck. Paraphimosis, right? What are you going to do? You're going to notify the charge nurse. And you wouldn't put heat on it because it's going to swell more. Actually, what they do is the physician will take cool water and that will shrink it a little bit and they're able to slowly pull it up. Because if it's not, that is going to tighten over the penis and it could cause tissue death. We leave it there too long. So, no,
This
we
would be
want
room temperature water, right, Professor?
warm, yes, room temperature. Well, not
Oh,
going to be hot or anything. And the physician does it.
okay.
Which urinary diversion procedure is the least damaging to the body image of an adolescent? Now, this is a hard one. We didn't really go into it. It is you have a problem because the urinary bladder, urethra aren't working. And you've got to put urine somewhere so that you're still getting urine out of the body. And it's something called an ilia conduit. The other stuff is on the outside. You have a tube hanging. So urostomy is a bag, nephrostomy is a bag, and a suprapubic placement, again, is a tube and a bag. Ilia conduit, they take the ureters, put it into the bowel, and it absorbs the fluid and it comes out that way. That's an ilia conduit. Which physical assessment will the nurse omit when caring for a 2-year-old diagnosed with Wilms tumor? Remember, Wilms tumor is an adrenal tumor, highly cancerous, and it's going to require surgery, radiation, or chemotherapy to get it out. And with this one, we don't want to do anything to touch that tumor. So no palpating the abdomen, as in you usually would palpate it. You'll listen to bowel sounds and all of a sudden you feel this big mass. No, leave it alone because that little tiny little manipulation could cause a little metastasis of that to go in the peritoneal cavity. And then you've got a metastasized kidney tumor now. What is the probable cause of acute glomerulonephritis? There's two things that this causes. It causes rheumatic fever and it causes acute glomerulonephritis. And it's probably a strep throat, right? Strep throat, rheumatic fever, or acute glomerulonephritis. How do we treat either? Long-term penicillin. A multi. What will the nurse caring for a newborn with exstrophy of the bladder include in the care plan? It's when the bladder is born on the outside of the body. What are we concerned about? We know the bladder is going to be put in about 2 days, usually, but they need to be on their back. They can't go on their belly. We want to protect the skin. Remember all the skin integrity. So it's not all irritated and we could close up the abdomen when we're done. And we're not going to have no diaper on that child. It's going to be actually leaning over. And if it's a male, just enough to keep their penis down. Okay. A child is brought to the ER with burns on the face and chest. It's the nurse's first priority. What did I tell you about burns? Remember, face, chest, worry about respirations. Very good. Another multi. What should the nurse stress or teach to the mother of a child with impetigo? That was the stuff that was on my grandson behind his knee. Ooey gooey juicy is what they were. Remember, it is strep that causes it, okay? And it's like either a bite, a cut, all of a sudden it becomes more and more gooey and juicy and that bullious. And they are, you would take a bath and I would dry them off and you'd see pieces of the skin on the towel. Of course, that went immediately into the washer. And I had gloves at home, thank goodness. But yes, it is very contagious staph infection. What factors activate the herpes simplex viral type 1? As in a cold sore on the lip, anything. Fever causes them to come up, stress, sun, period, hormones, everything can cause the herpes virus type 1 to come up. Football players are taking oral griflosivin for tinea pedis. What should the school nurse caution them to avoid? Well, what is a tinea pedis? Again, it's a fungal infection. Grisafulzin, that is an antifungal medication. Now, antifungal medications are pretty unique. You cannot have a drink with them because you'll be in profuse vomiting. It's like taking what they do for alcoholics. They give them antabuse. And if they take any alcohol, they'll be in profuse vomiting. Well, an antifungal like this one is the same thing. So again, avoid alcohol. What is the correct nursing response to a mother who asks, can I get rid of the baby's cradle cap? So I think the best one is let's put oil on it. Let's get it lubricated up at night. And then in the morning when they wake up, then we'll take a shampoo and very easily a soft bristled comb and take it out. And again, it's not going to happen overnight. It's going to take a couple times to do it. Child is experiencing intense itching axilla between the fingers, worse at night. What is this? Which is the one I said is itchy, itchy, itchy. Because you've got the bugs in there, and then you've got their eggs being laid. It's scabies. That's the big one. It is scabies. At night, I mean, this is because it's a bug. Eczema, yes, it itches, but it's not worse at night. It's all the time itching. Okay, that's your difference. An adolescent presents with a fly rash. What diagnosis does the nurse suspect? That's lupus, right? Butterfly, classic. Another multi. Which food sources are high in soluble fiber? You know, one of the things children do suffer with, toddlers, preschooler, is constipation. So, what would you give them? What could help them? And they're picky eaters too, so it's hard. But it's raw fruits actually and beans. Now, ran cereal, okay, I'm going to have to change this. It is, but it's not cooked vegetables, raw fruits. Those are your best choices. A glycosated hemoglobin A1C test can evaluate average glucose levels over a period of blank to blank months. So we're looking, are you diabetic? And remember, when we look at children, it could be 7 and up to 10. In fact, at 10, they say it's not regulated. So it's 3 to 4 months, not 2 to 3, it's 3 to 4 months. We're looking at where was that glucose all along. We can actually even tell the compliance with monitoring blood sugars and giving insulin according to a hemoglobin A1C. So that's your telltale sign what's going on. What occurs as a result of an inadequate secretion of insulin? Your body does not secrete enough insulin. What happens? So what happens is you can't use sugar and you can't use carbohydrates. So you have an increased fat breakdown, which leads to ketonuria. So serum glucose are going to be increased. Protein synthesis is increased. It goes first to fat, then to protein. And then more conversion and storage of carbohydrates to glucose. What happens is it's just sugar in the blood. It doesn't store, it's just free flowing in the blood. So it is that increased fat breakdown, and you see ketonuria. The child receives a combination of regular and NPH insulin at 8 o'clock. At 8:45, the breakfast trays are still not arrived. What are you going to be concerned with? They got regular insulin and NPH at 8 o'clock. And 45 minutes later, breakfast trays aren't there. Do you need to be concerned about anything? That regular insulin's going to start to work and they're going to go into, hypoglycemia until we give them something. So, yes, graham crackers, milk, great thing. A child with diabetes is brought into the ER. He's flushed and drowsy, and his skin is dry. The child is experiencing what? And that is your ketoacidosis. Diabetes, the skin is dry, they're always dehydrated, and they just are drowsy, lack in their level of consciousness. That pointed me to ketoacidosis. A child with type 1 mellitus has hyperglycemia, diaphoresis, and headaches in the morning. What's that condition? Those are those phenomenons that I'm telling you about, how some children feel differently. And that one's this emoji phenomenon. It's just the name of it that in the morning we know the blood sugar is going to be there. They're going to be, sweaty and they're going to have headaches. And that's part of that. So they need to reorder the insulins to make it different for that child. So what's the function of an insulin pump? So it's a continuous and small infusion of insulin. And why is it so good? Well, you stick that one needle in and you put the dressing on top. We can leave that with that little tube and that little pump on. Could stay in there for a week instead of doing 4, 6, 8, 10 injections a day. It is a good choice when the child's alert enough to be able to work it by themselves. Multi. What signs and symptoms will alert parents of the possibility of ketoacidosis? Ketoacidosis. Blood sugars are really elevated. Ketones are in the urine. What are you going to see? and you're gonna smell it. I mean, when those blood sugars get to 6.8, I've seen them 1,000. That was the 6.8 pH that I was talking about. Was over 1,000, and you could smell. They oozed sugar out of their pores, and they're nauseous because they feel just so horrible. So those are things. Very good, guys. I'll multi-select. Why are children more prone to insulin reactions? Well, think about children. Are they always on a schedule to do the same thing all the time? Or do they get up and run and then they sit and up and run and come sit? They're all over the place, aren't they? They're still growing, they're all over the place. Some of them burn up insulin quicker than other ones, or they're sitting because they don't feel well today. So you're going to see those up and down reactions. It's just part of it with children. That's why we always have to have something sweet with us. What type of precautions are necessary for varicella? Chickenpox. And remember, if we ever suspect a child with this, we need to get them in that airflow room. And first of all, you put your N95 mask on to make sure that you are protecting yourself. It's airborne. What vaccine would be contraindicated for an 18-month-old child allergic to eggs? Which one is it? It's influenza. Good job. A child's rash was present on the trunk, extremity, face, and the cheeks were bright red. This type of rash is now this bright red slap in the face, cheeks, is a viral rash, and it's called fifth disease. It's what they say that it looks like you have slapped both cheeks and they are bright red, and there's this rash all over the place. It's virus, and it's treated Tylenol, Motrin, rest, and fluids. And many children, they spread it from kid to kid to kid, but it's those big red cheeks. It's always fifth disease. A child is in the prodromal stage of varicella. What does this mean? We talked about when we are exposed to things and don't even know we're exposed, and the time that it takes from being exposed till when they break out with a rash. That is that prodromal period. So they have it, but they, are not showing outward signs. That's when they are contagious, and that's when they can give it to you. When should hepatitis B vaccine be given to the infants of a Hep B positive mother? So, the mother has hepatitis B. We know that hepatitis B is your first vaccine. So, with that additional information, when do you think we should give it? Seems a little more urgent, isn't it? Yes, within 12 hours after birth. Which classification of medication would make a child more susceptible to an opportunistic infection? So that's another way here. A child who's immunosuppressed. What are you worried about, right? What those child, they're more susceptible. And it's those childs on steroids. Very good. And last question. A multi. What sources are examples of acquired immunity? How did you acquire the immunity? That's how I ask. So you either got the vaccine or you got the disease. Those are your sources. See how we did today. Trish, good job, Trish. NR, good job, NR. Number one. Danny, good job, Danny. Number four, Brianna and Courtney. A lot of interesting questions in there. You know, I can't go over it all on a PowerPoint, trying to fit it all in. So, you know, this allows me to look at you and give those extra things that I can't fit in just one place. So, anybody have any questions, comments, concerns? All right, remember next
Sorry, I have
Thursday.
a question.
Sure.
Oh, I think you were just about to answer it. Next Thursday, what was it?
6 o'clock. We're going